Thank you all for joining us this morning. My name is Rachel. I'm going to go ahead and get us started here in just a couple minutes. First, I just want to run through some things for anyone who has not joined a webinar with us before. First thing is at the bottom of your screen, you should see the option to chat, raise your hand, or the question and answer box. At any time you have a question, please feel free to go ahead and write it in that question and answer box. We will answer them live at the end of our webinar. So to go ahead and work on getting that started here, I'll go ahead and introduce Dr. Talone. Dr. Talone is an optometrist here at Nittany Eye Associates. He is also the clinical director over at the Laser Center of Central PA, which is housed within Nittany Eye Associates. So Dr. Talone, I'm going to go ahead and hand that on over to you, and I'll come back in at the end of your webinar.
Great, thank you, Rachel. I would be included in that group of first-time webinar participants for Nittany Eye. So this is something that's new for me, and so hopefully everyone can hear me. Rachel, can you confirm for me that everyone can hear me? Can you hear me?
Yeah, it looks great, Dr. Talone. I can hear you and I can see your screen.
Good. Okay, perfect. Good. Well, thank you all for spending some time with us on a beautiful Thursday morning. We wanted to, in some way, keep connected to our patients. And so this is one way that we thought as a practice that we can continue to engage and be a resource to all of our patients. And so over the last few weeks, we have continued and remained open. So I wanted to just take some time to kind of give all of you just a little bit of an update on Nittany Eye. We have been continuing to care for patients. We remained open through the entire closure in general of Pennsylvania, and we're anticipating opening up here soon in a very slow and careful, conservative way. We've been taking care of patients for urgent and emergency care, and that's been an interesting thing because we're getting a lot of questions as it relates to the COVID disease, as well as its effects on the eye, and how we are going to be taking care of that, number one, and number two, how that affects, especially with contact lenses. So I'm going to take some time and just kind of go through some of those things. And so feel free to ask a question in the chat box if you have. And I'm going to ask Rachel to help me if I miss those. And so feel free to interrupt me if you need to, Rachel. As I mentioned, you know, as we're all staying at home, not having much to do, we all, many of you have been gardening and doing home projects. And so as a result, we've been seeing a lot of people with corneal abrasions from grinding things and doing home projects. So we've continued to care for those patients. We plan a slow open next week to include routine care. And so that will include a reduced schedule to limit patients' interactions with each other and to obey and sort of heed those social distancing recommendations. So we won't be operational at our full capacity, but it'll be a slow and kind of gradual opening. But for those of you that have a more immediate need for eyeglasses and contact lenses, we do anticipate opening up next week. And of course, we have been working very hard over the last couple of weeks to develop proper cleaning and disinfecting protocols. So the care and safety of our patients is priority. And so we feel comfortable in what we have put together in terms of that. We've also been engaged in telemedicine consults, and this is something that we anticipate will continue, and frankly, we hope to build upon it. Our interaction with patients, particularly those patients that need access to care, but were at high risk, for example, the elderly that had eye infections and other eye problems, we've been able to reach out to them and help them remotely. Last week, I had a telemedicine consult with a 91-year-old woman who did fantastic. She probably understands technology better than I did. And so she loved it. And I think we anticipate interacting with our patients in a larger way, in a larger percentage way through telemedicine moving forward. We're able to dispense eyewear and contact lenses as well as supplements. Those of you that get your supplements for dry eye and fish oil and things like that through our locker system. So you can see that picture down at the bottom. And that's a locker system that works great. We can send you a QR code and text that to you or email that to you. And we have some instructions on how to use that, but it allows you to come by and pick items up and not have to necessarily come into the office, and limits exposure and things like that. So it's a very convenient and easy way for us to get you what you need. And of course, that's sanitized and wiped down after every interaction. I wanted to just take a couple minutes and just go over with all of you the common questions that we're getting around SARS-CoV-2, which is actually the virus which causes COVID-19. And so SARS-CoV-2 can affect the eye. And so there's more information coming out, so this can change, but it seems to affect a small percentage of patients. And the most primary potential manifestation of COVID-19 disease in the eye is what we call a conjunctivitis. And this is where the white part of the eye that gets swollen, conjunctival. There you have what's called a palpebral conjunctiva, which is on the inner lining of the eyelid. That becomes red and swollen. The eye becomes a little bit more watery than normal. And it's kind of a similar thing to your regular adenoviruses that we see, like the flu virus. And so there appears to be a small percentage of people that can have manifestations within the eye. They seem to be somewhat mild in their presentation, and they do tend to be more common in more severe cases. So those patients that have more mild manifestations of the disease tend to not get symptoms in the eye as much as those severe cases. So we think that in a small study of about 38 patients, 2 patients showed eye manifestations, and several other studies seem to suggest that the incidence in affecting the eye is relatively low. There is, as it relates to, we've had a lot of questions with this regarding contact lens use and eyeglass use. Which is better? What should I be doing? There's no evidence to suggest that there's an increased risk of contracting COVID-19 through contact lens wear. And that's according to Contact Lens and Anterior Segment this month. They just came out with an article. There's numerous posts through the American Academy of Optometry and Ophthalmology and the American Optometric Association. These are all organizations that are in agreement that your normal cleaning regimen that we would recommend regardless is adequate to prevent the spread of the virus as far as we know as it relates to contact lenses. So we don't perceive that there's an increased risk of infection or contact through contact lens as long as those disinfecting regimens are adhered to. And so as always, we often recommend daily disposable contact lenses anyway. That's probably moving forward an ideal way to approach contact lenses. We think that can help reduce the risk of transmission and infection from coming into contact lenses or contaminated surfaces. Appropriate hand washing before and after, of course, we recommend that anyway, and contact lens replacement or cleaning with an appropriate contact lens disinfecting solution. So these are your multi-purpose solutions that you can get over the counter and at the drugstore. And one thing to remember is don't forget to clean your contact lens case. That's a really important thing. Patients sometimes I've come across can do a really good job of cleaning the lens itself, but they bring their contact lens cases in sometimes, and sometimes I cringe by the appearance of those. So don't forget to keep keep tabs on your contact lens case also. Eyeglasses, we're getting a lot of questions about fogging, and this is a little bit of an issue as we all are wearing masks in public, and eyeglasses, more and more, we're getting a lot of calls regarding LASIK, which is the reason for this webinar. That glasses are becoming increasingly, if they weren't before a nuisance, they certainly are now with the need to wear a mask. And so not only the fit of the eyewear on the bridge of the nose where the mask meets it, but fogging. And so I thought I'd mention just a little bit of some tips there that might be helpful. Fit the mask as close to the bridge of your nose as you can. That's going to limit some of that warm air that's coming up from deflection of the mask onto the surface of the lens and causing that condensation to occur. Washing your eyeglasses with soap and warm water, and doing your best to let it air dry. That soap can act as a surfactant and help to reduce that condensation from occurring. So that's a helpful thing. And of course, there are anti-fogging products out there that have traditionally been used for things like ski goggles and scuba masks. And of course, the topic of the hour is, LASIK. How can we get rid of the eyeglasses altogether? And so we are getting a lot of questions regarding options moving forward with, kind of ditching the contact lenses and eyeglasses. So what is LASIK? LASIK stands for a complicated term called laser-assisted in situ keratomileusis. And basically what that is a fancy way of saying we're using a laser to reshape the surface of the cornea. And we can effectively treat many different types of eye maladies as it relates to eyeglasses, from nearsightedness to farsightedness and astigmatism. So we essentially are using lasers to reshape the surface of the lens of the eye. And this is a 15-minute procedure, outpatient with topical anesthetic. So there's no general anesthesia needed. It's an outpatient thing, and you go in the laser room. 15 minutes later, you come out, both eyes in a very short period of time. So if we're going to talk a little bit about how we're going to help someone see without glasses or contacts, it's helpful to just understand a little bit of what's happening behind the scenes as to why some of us need eyeglasses and contacts. So if you look at the screen here, myopia or nearsightedness is the most common type of correction that we see. And this is a situation where that outer lens of the eye, the cornea, has too much focusing power. So light that enters the eye becomes focused in front of the retina as opposed to being perfectly focused on the retina. The opposite of that is something called hyperopia or farsightedness. And this is where that outer lens of the eye doesn't have quite enough focusing power, and that causes the focal point to lie behind the retina. And thirdly, you have this thing that a lot of people know about and understand that they have, but they don't quite understand what it is, and that's something called astigmatism. Astigmatism is the shape of the cornea is not perfectly spherical. And so the best way that I can describe that is if you can think of a basketball, and if you cut a basketball in half, and you think of that half of a basketball as a lens, the curvature of that basketball is the same over the surface of the lens. So that is when you think of a football is a very different shape. If you cut a football in half, we know that there's a different curvature along the length of the football compared to its width. So astigmatism is more football-shaped lens, and that causes a doubling or a ghosting effect in how the light entering the eye is focused. So how do we fix it? Basically, in a nutshell, the LASIK procedure is involved with creating this, if you see in the top left there, creating this corneal flap. And we get a lot of questions as to why do we do this flap? What's the purpose of the flap? And so your eye is very much like your skin. It has cells on the surface of it that are constantly being replaced and slough off each day. So we're constantly producing more of them. And so if we just do use the laser to reshape the outer lens, those surface cells will just grow back. So it doesn't become a permanent correction. So you have a layer of tissue underneath the skin cells of the cornea called the stroma. And the stroma it is not a replaceable tissue. So we use this technology to fold the top layers of cells away. We need to gain access to that middle layer of the cornea to reshape it permanently. And so this flap allows us to do that and gain access to the middle, whereas you see in the second picture there, you see that blue, the laser light is represented by that blue shading. That is the laser that actually reshapes the surface of the eye. And then we fold and lay that tissue back down, and the procedure is done. So it's basically a three-step process. We create this flap to gain access to the middle layers of the cornea. We reshape the laser, or we reshape the lens of the eye with a laser, and then we put that flap back down. So essentially what it is. And we do that in a way that is called blade-free. And blade-free is the newer version of LASIK. There are many different ways and procedures that have evolved over the years that are essential variants of that concept, which is LASIK that I just went over. At Nittany, the only way we do laser is with LASIK is with a blade-free approach. You can create that flap with a machine called a microkeratome, and that uses a blade to cut the flap. And that's an older style of LASIK that is still around. You can still find places that do it, but Nittany does not do it anymore because we know that using a laser to create the flap or a blade-free approach is safer and more effective. And we'll talk a little bit about that moving forward. But we do create that flap with a laser, and the laser effectively is making these little pulses, applying those little pulses to the laser, which allows it to separate the tissue and allows us to fold it back. So it creates these thousands of uniform little microscopic bubbles that separate the tissue very gently. And so we can create that flap. It's about 110 microns thick, which is less than the thickness of a human hair. The benefits of blade-free LASIK is, first and foremost, it's safer. And so there are a whole host of complications that can, and some of them serious, that can come as the result of problems with a blade coming in contact with the surface of the cornea. And so avoiding that gives us better safety profiles. LASIK is a very safe procedure with very few risks, and blade-free approach helps to reduce those risks in a significant way. It's more comfortable, especially for patients. It's been around for several years. It provides better vision, so more patients achieve a better than 20/20 result with blade-free versus with the older style microkeratome. And it allows us to create that flap as it relates to the individual patient's eye characteristics. So we might change our approach with the software that comes on the laser based on the individual characteristics of that person's eye. So using a blade doesn't allow us to do that. And patients that have gone through both procedures prefer the blade-free approach because it's more comfortable. The second part is what we do is called custom LASIK. So you have this initial step where we create the flap that uses one laser. It's a two-laser process. So the second step, where we reshape the surface of the eye, we use a different laser called an excimer laser. And that excimer laser is actually what does the resurfacing and reshaping of the eye. And that's a really important part because the shape of our eyes are all unique. Each one of our eyes interacts with light in a very unique way, much like your fingerprint. We all have different fingerprints. And so we're able to measure the way the eyes focus much more precisely. And now that allows us to reshape the surface of the eye more precisely, and thus provides us with better outcomes. So step one, we use a laser to create the flap. Step two, we use a second laser, which measures our vision 25 times more accurately than your traditional, which is better 1 or 2 test. Everybody, I'm sure, has taken that. And so that's a very effective way of measuring vision, but this is a more precise way that we utilize when we are reshaping the eye with LASIK. Advantages of custom LASIK is that it provides much better visual acuity than the older procedures. So if you do some reading and research, you'll come across patients that were early adopters that had LASIK in the late 90s or early 2000s, and that some of the risk factors, the common ones, were problems with night glare and halos around lights. And custom LASIK was a direct reason. The development of that technology was designed to address that, and it reduces the risk of those kinds of problems that we were finding in those early patients. And so it provides a better outcome in terms of visual acuity, and it provides a better outcome in terms of quality of vision, things like night vision and overall satisfaction with vision. Again, looking at the differences between using some of this newer technology and some of the older technology, essentially it boils down to we're able to take more precise measurements of the eye than we've ever been able to before, and that gives us better information to guide and direct the laser to reshape the eye for that individual patient. We don't perform the other older procedures. So we occasionally will have patients ask us why we don't do those procedures. And the reason we don't is that there's not a real good, compelling reason to offer them. They're older technology, the risks of complications are higher, and the results in terms of visual acuity aren't as good. And so we don't offer them to our patients. So how do we find out if this is a good option for patients? And I think this is probably where things are most important, that this time that we spend with our patients to kind of understand what their eyes are like and what their goals and frustrations are with their current mode of correction. That's the most important part of the process. And so we often will perform or in every case, perform what we call a consult. This LASIK consult allows us to kind of look at, are there any risk factors for this individual to have any particular problems? Is there anything that we can find about their eyes that is a reason to not do the procedure? And so that's a very straightforward process. We take measurements of the shape of the cornea. We take measurements of the thickness of the cornea. We look at how nearsighted or farsighted or how much astigmatism that person has. And we do a whole host of other measurements to help determine whether that patient is a good candidate or not. And so this is where I think that we excel. And I think being an elective procedure, it's something that if we're able to choose the right patients and choose the safest conditions to administer or deliver this kind of help, then the results are happy patients and good results. And we've been happy to provide this service in a safe and effective way to the State College region for 20 years. So this is an example of us measuring the shape of the cornea prior to LASIK to kind of help us get an idea. If we're going to be reshaping the eye, we want to know what the shape of the eye is like to begin with, and that gives us a lot of information. So these are all painless and helpful ways that we can measure and screen patients as to whether LASIK is right for them. So Rachel, I'm done talking. I've talked enough. And so I would like to see if there are any questions that anyone has. I can't see a cursor here. It looks like we might have one question, but I can't seem to, there we go.
I have that question here, Dr. Talone. I can go ahead and ask it for you. And if anyone else has questions, please feel free to send them in using that question and answer box at the bottom. But we'll start here. Please explain how you do LASIK so that those who need reading glasses can see near as well as far. And how does this affect one's ability to perform in sports and target or skeet shooting?
Okay, I think I can see that now. That's from Kimberly. Thank you, Kimberly. So what we do is, I'm 47 years old, so I'm starting to have this this loss of the ability to focus my eyes up close as well. And so, assuming that's what's going on with you. And so the way our eyes work is, in an ideal situation, if our eyes are focused perfectly far away, we have an autofocus or auto-correcting mechanism that when we go to read something, there's a muscle inside the eye that contracts. And that muscle is attached to a lens that is very flexible. So the eye is built with this autofocus mechanism that it becomes less effective as over time. And so we do this thing called monovision. So in a normal situation, when you become usually for most of us in our 40s, at some point in our 40s, we start losing the ability to focus the eye because that lens inside becomes less flexible. And so what we do with those patients, we often do this with contact lens patients as well, is we correct one eye to see far away, and the other eye, we correct almost all of the nearsightedness, but we leave a little bit there because nearsightedness helps people see up close. So we have one eye that helps to read and the other eye that helps to see far away. And so that is something that can be very effective at helping patients not need reading glasses afterwards. As far as skeet shooting is concerned, I'm not, I have done some skeet shooting. I think that probably the best way to answer that is probably it's an individual preference. So what we find is that some patients do very well with monovision. Some patients don't really like the idea. They don't get along with that concept of having one eye see far and the other eye read up close. So what we do before we do monovision on anyone, what we do is we often will fit them in a contact lens that simulates what monovision would look like. So in the case of skeet shooting, if that's something that's kind of important to you, what we would do is we would fit you in a contact lens for some period of time, a week or two, or however long it's needed. And we would let you go practice skeet shooting and go throughout your normal day, go to work, do your normal activities. And that gives us usually a very good sense as to whether someone will like monovision and be successful with it. And so doing that gives us a very effective tool at making sure that that's the right decision for the patient. In the 20 years that I've been involved with this, we have had a few patients over the years that decided they wanted monovision. We did it, it was effective, and they decided later on down the road that wasn't something that they wanted to continue to do. So we can correct it with additional laser treatments if needed. But we try to sort of make sure that we're all on the same page ahead of time by doing the contact lens trial. So monovision is generally the preferred method of reducing the need for readers after LASIK. I see another question here. What is the ideal thickness measurement of a cornea to be eligible for the procedure? And so that is the average, depending on which study you look at, the average corneal thickness is around 530 microns. And so if you look at FDA recommendations, the FDA has recommended that we not, of course, when we are doing laser, we're removing small amounts of tissue from the surface of the eye. So there is a relationship between the amount of tissue that we remove and the degree of correction that we need. So if someone's really nearsighted, we have to remove more tissue than someone who's less nearsighted. So corneal thickness is important in all cases, but can be sometimes more important for more nearsighted people. So in general, we know we need to leave most patients with at least about 400 microns of corneal thickness. So if the average corneal thickness is about 530 microns, roughly for the average patient, we have about 130 microns to work with. And so that translates roughly to around 8.5 diopters or units of nearsightedness. So if you look at your contact lenses or your eyeglasses, that minus number, -7 or -4, that's the degree of nearsightedness of that individual. And so it varies. Some people have much thicker corneas, some people have thinner corneas. And so that's part of what we're evaluating during the consult process to make sure that that person's nearsightedness and the amount of their corneal thickness is a correct relationship. So hopefully we answered that question. What are the costs? The costs can vary. We do two types of laser. I didn't really talk about a procedure called PRK. Sometimes PRK, instead of making the flap, we use just the second laser. And so the cost, depending on, there are certain situations clinically that we might find where we would prefer to do a PRK procedure as opposed to a LASIK procedure. So sometimes the cost can vary based on the types of lasers that we use. So PRK generally, because we're only using one laser, tends to be a little bit less costly. So the cost can range anywhere from $4,000 to about $4,500, $4,800, depending on the procedure that we do. But in general, that's the range that the costs come in at. And that includes what we call our lifetime commitment program. And that basically says that we see a lot of patients that come in looking and that have interest in LASIK. And a lot of times their question is, how permanent is this treatment? And no one can really predict that. There's plenty of laser studies that show that LASIK and PRK can be an effective long-term solution to correcting nearsightedness and farsightedness and astigmatism. There are very few patients, about 4% of the time, will need to go back and do retreatments. So generally, 90-some% of the time, we do it once and it's a permanent treatment. We don't need to go back. But sometimes patients will need further retreatments, and that is included. So if down the road, patients have a shift or a change in vision that we can't predict, that's included in the cost for the long term. Danielle asks a question, does chronic dry eye lead to any issues with undergoing LASIK? And the answer is that it certainly can. And so as we go back to the consult process, part of the consultation process is looking and evaluating what the tear system of the eyes are doing and how effective they are. We see a broad range of patients in that in most of our patients have very normal, adequate tear function. Occasionally we'll find patients that come to see us because they're sort of at the end of their rope. They can't tolerate contact lenses. Their eyes are dry and red and inflamed all the time. Their eyes are uncomfortable. We know that LASIK can induce dryness in some patients. In the majority of cases, that dryness is short-lived, usually by about 2 to 3 months. If you look at the studies, they can vary from patient to patient, but in general, almost all patients will experience some level of dryness immediately after LASIK. And over the course of time, 2 to 3 months, generally that gets better and goes away. we can't always predict. In some cases, that dryness doesn't go away altogether. So we can't always predict who those patients will be, that the dryness doesn't go away altogether. And so if we find that patients prior to LASIK have reduced tear film production, their eyes are severely or significantly dry to begin with, we will often recommend against having the procedure. So that's something that we take very seriously, but the majority of patients do very well and their dryness is short-lived. Kim is 47 as well. I play volleyball and mainly wonder how it affects depth perception for fast-moving objects and balls. So that's a good question. So monovision will affect, if we do monovision, if both eyes are corrected for full distance vision, laser will not have any negative effect on depth perception. If we do end up doing monovision on someone because they're 47 and they don't want to wear glasses to read with, it will slightly reduce the depth perception. And so for a lot of patients that are my age, 47, your age, Kim, that are interested in laser, we often, if the patient tolerates it and does well on a day-to-day basis with monovision, if they do very well with it, we often will recommend that we do laser that way. Unless you're a professional volleyball player, which you very well could be, you probably are playing volleyball more on a recreational basis. And so for most patients, and that may not be the case for you, Kim, but for most patients, you'll spend most of your time not playing volleyball. So monovision is often the preferable way to set things up so that you can live your life without wearing reading glasses or bothering with them. For some patients that have hobbies that they take very seriously, we can just simply pop a contact lens in the eye for certain activities like that represent a relatively small percentage of your overall life. And so, of course, the idea is not to wear glasses or contact lenses after laser, but there's no scenario for a above 40 some year old that will never need glasses at all. And monovision represents the most amount of time being glasses free. And so having a corrective lens or a contact that you pop in the one eye, go play a volleyball, you throw it away, and it often is a good remedy to those kinds of situations. Next question is, how does pupil size affect the outcome of LASIK surgery if the procedure is conducted on the cornea? So pupil size, we know, can affect one's risk for difficulty with night vision. So the average pupil size, again, depending on which study you look at, ranges anywhere from, on average, is about 6 millimeters. And so we measure pupil size prior to, in the consultation process. And the reason we measure pupil size is that there are some patients that have very large pupils. And patients that have large pupils can be more at risk for having difficulty with their night vision than those patients that have smaller pupils. So there's about 3 or 4 general risk factors that can make someone more at risk for having those kinds of night vision problems. And you've touched on one of them. Pupil size is one. Those patients that have a severe or large degree of nearsightedness is another. Patients that have large degrees of astigmatism, and patients who have relatively a low degree of curvature of their cornea prior to having LASIK. So for example, someone that's really nearsighted, that has a large pupil size, that has a lot of astigmatism, is someone that is at most risk for having difficulty with glare and halos postoperatively. So that's likely a patient that we would advise against having LASIK or PRK. So part of that consultation process is weeding out those patients that are more at risk for having those particular potential complications and avoiding doing the procedure in the beginning, to begin with. Barbara asks, can you have cataract and LASIK surgery at the same time? That's a really good question. The cataract surgery is often, when we do cataract surgery, we are removing cloudy, a cataract is a cloudy material, the lens inside the eye, not the outer lens of the eye that we've been referencing through the webinar. But there's another lens inside the eye that becomes cloudy over time. And cataract surgery essentially goes into the eye and removes that cloudy lens and puts a brand new artificial lens inside the eye. So often we don't need to do cataract surgery and LASIK because the simple replacement of the cloudy lens, this artificial lens that we put inside the eye, we can put your eyeglass prescription in it. So we often can correct vision like LASIK does by doing and removing the cataract itself. Now, those measurements, the calculation of the lens that we put inside the eye, are extremely accurate, but they're not perfect. So occasionally after cataract surgery, we try to make patients as glasses free as possible after cataract surgery, but sometimes that doesn't always turn out perfect. And we can do a subsequent laser procedure after cataract surgery to fine tune or sharpen vision where the cataract surgery didn't correct it completely. And so we often will approach and remove the cataract first. We wait some time for the eye to heal. And in 99 out of 100 cases, the cataract surgery is good enough to correct vision, but there are a few cases that we can go back and perform laser on to fine tune vision. What if you also have cataracts? Hopefully that answers Malcolm's question. If we remove the cataract, we often won't need to do LASIK, and insurance covers the cataract removal generally. So that's considered a medical condition. So if you have medical insurance, then cataract surgery is covered by that, and oftentimes patients don't need to wear glasses after cataract surgery. Very similar to, sometimes we do monovision with cataract patients. There are other new lenses that have that can be right for some patients, so they don't need to wear glasses at all. And so that's usually covered by medical insurance. Lori asks, in general, if the patient is older, are the odds of a good candidate for LASIK lower? Older as in over 45 years with normal eye changes. So there's not really been shown a correlation between the effectiveness of laser and age. So in other words, if you take two patients that one is 25 years old and they're -3, and you have a 50-year-old that's -3, I would not expect there to be much difference in outcome between those two. So age will not generally have an effect on outcome, other than perhaps our approach on how we might want to approach correcting it as it relates to the loss of vision or presbyopia in their up-close vision. So the outcomes should be just as good. Are there lots of trigeminal nerve endings of the cornea which will LASIK affect corneal sensitivity and lead to neuropathic pain? If yes, why do doctors still recommend this procedure in spite of the risks involved? So the cornea has a extremely large number of pain receptors. And so generally, there are some reported cases where patients can have discomfort, particularly dryness or irritation of the cornea. And so those are few and far between. And so generally LASIK does not cause any long-term pain or discomfort. And so there are certain risk factors that are part of the decision-making process as someone considers LASIK. So things like infection, we've touched on some of them in terms of dryness. We've touched on how LASIK can sometimes affect quality of vision. So if someone is having or has a history of chronic pain with their eyes, or their eyes are generally more sensitive. These are situations that we do our best to uncover in the consult process and avoid treating those patients. So it's like any other surgery. There certainly are potential complications and problems that can result, and that's part of the decision-making process. But in general, I believe that the LASIK is a procedure that has very low risk of potential complications and problems, and has certainly a lot of upside, and can really, and has been shown to really help a lot of people with quality of life as it relates to the dependence on glasses and contact lenses. So I believe certainly there are risks, but I believe that in general, most people, if you talk to them that have undergone the procedure, they will often say, I waited too long to have it done. It's one of the best things I've ever done. So I think that because of that, I think I mentioned this earlier, I think the key is to make sure that we do this on the right person. We do our best to identify those risk factors and avoid doing this on the wrong people. And when we're able to do that effectively, LASIK is a positive procedure that is fun to be a part of. Okay, I think that about wraps it up. Thank you all. I guess we got one more question here. In general, what is the recovery time? 1 or more days at home in the dark and covered and constant eye drops. So recovery is pretty quick. So in general, if we're able to do LASIK, what's nice about LASIK is recovery is pretty straightforward. We generally do cases on Thursdays or Fridays, and we recommend that most patients go home and take a nap. Usually, if you're like most, patients will have a little bit of irritation, some stinging or watering in their eyes for usually about 2 hours after the procedure. So we recommend patients go home and go to sleep, take a nap. Usually by the time they wake up, their eyes, that irritation, stinging, burning goes away, and they're able to watch TV and do other things later. We don't recommend they do a lot of that, but in general, patients feel pretty good later in the day. The next day, most patients see well enough to drive. And so they're, aside from swimming or, any real vigorous computer use or anything like that, most patients can resume normal activities pretty quickly, go back to work in a couple of days. And so recovery time is pretty quick. Thank you. Any other final questions that you have? Rachel, I'll leave it up to you. Thank you for helping me through this.
Absolutely. Thank you, Dr. Talone. That was a great presentation. And I will just add in one final thought. As someone who just got LASIK this year, I will say I feel the same way. I waited too long, and I'm happy I have it now. But we do a great job. I felt very comfortable through the whole process. So thank you all for coming and joining us today and for your wonderful questions. If you have more, please feel free to send them over to us. We do have consultations. More information can be found on our website. It's tlcofpa.com. But otherwise, this will be available online later. And again, thank you all for coming out, and thank you, Dr. Talone.
Thank you, Rachel.